Time now for a look at your health. Our topic tonight is something called overdiagnosis and overtreatment of cancer. In fact, many times there are certain conditions that don't need to be treated quite as aggressively. And here to talk about what's necessary and what's not is Dr. Mitchel Goldman from UCSD. As always on Tuesdays, thank you for being here.
Great to be here.
Well, let's talk about what this whole concept of defensive medicine is.
It's real. You know, doctors don't want to make mistakes. Doctors want to do their best for patients. But these days, we have to be so careful. We don't want to miss anything, because if you miss something, you're going to end up getting sued.
And this drives up insurance costs by over-diagnosing through what you call screenings, right? Too many tests and too many biopsies and things of that nature?
It really does. It's been estimated that 10 to 30% of our health care costs are on overdiagnosis and too many tests. And then the bad thing is, when we do a test and we find that something is a pre-cancer, is it really a cancer? And is it really going to progress to something that's life-threatening? And we know more and more now that some things that we call cancer really don't progress and don't even need to be treated.
I think the American Cancer Institute was talking about that recently.
Yes, and this was just published in the Journal of the American Medical Association. So what we want to try to do is try to use the word cancer when it's going to become a life-threatening condition. But don't just throw around the word cancer, because it could be really stigmatizing. If you get a diagnosis of let's say something called a dysplastic nevus or a melanoma in situ, you're never going to be able to get life insurance again. But yet the type of cancer, dysplastic nevus and melanoma in situ, may never evolve into anything that's going to be life-threatening.
And let's talk more about that, because these are some of the things that are generally overtreated, and we actually have that information because those are big medical terms that for us to memorize are difficult, but we have that on the screen.
Well, actinic keratoses are what people thought were pre-skin cancers of squamous cell. It turns out it's less than 0.1% of them will actually evolve. Dysplastic nevi, we thought at one time that they were going to progress to the fatal cancer called melanoma. We now know that that doesn't happen. Barrett's esophagitis, it's an inflammation that sometimes comes with gastric reflux. That doesn't really progress to esophageal cancer. And then there's one form of breast cancer, which is fairly rare, intraductal breast cancer or ductal carcinoma, which really also doesn't progress.
So those are things to keep in mind if in fact those are something that your doctor says that you may have, and how you want to approach that treatment. Let's talk though about the screenings that are absolutely necessary, because we don't want to send the message that, oh, don't worry about it. You don't have to dot your I's and cross your T's. There are some that are very necessary.
Absolutely, Kathleen. We don't want to give that message to our viewers. You know, colon screening, very important. Start at age 50 and every 10 years afterwards, unless there's a family history. You want to do it more frequently. You want to also always screen for breast cancer. Picking up breast cancers early can give you a cure. And finally, cervical cancer. Make sure women get their pap smears once a year. Those are 3 tried and true screenings, very easy to do, that really save a lot of lives.
All right. Thank you for bringing this to our attention. Always good to see you, Dr. Mitchel Goldman.
You too, Kathleen.
Every Tuesday. Right here, Walter.
All right. Thanks.